Welcome back to the deep dive. Today, we are really undertaking quite a critical mission. We're aiming to master the updated anatomy of the digestive tract. Specifically, we're zeroing in on those anatomical structures that, well, they form the foundation for pretty much all gastrointestinal surgery. We're talking about the peritoneum, the peritoneal cavity, and maybe most importantly, the mesentery. So if you're here to get that expert level knowledge, the kind that goes way beyond the old definitions and really informs every precise move in procedures like complete mesocolic excision or total mesorectal excision, well, this is definitely the deep dive for you.
Indeed it is. We're facing a genuine paradigm shift here. It's something cemented by modern imaging, surgical experience, and it's now baked into texts like Gray's Surgical Anatomy. And the core idea, the revolutionary concept we really need to internalize is this. The mesentery isn't some fragmented collection of different folds or attachments. It's actually a single, continuous functional organ. And it extends without any interruption right from the esophagus down to the rectum.
Right, that continuity. That seems to be the absolute key to unlocking modern surgical success. We're moving past that historical ambiguity, embracing a model that's, evidence-based, universally applicable. And as you said, the stakes are incredibly high. This understanding underpins these really complex critical procedures, things like total gastrectomy, pancreatic duodenectomy, and that whole spectrum of cancer resections like complete mesocolic excision, that's CME, and total mesorectal excision, TME. So our goal today is mastery, understanding the architecture of this continuous organ and the very precise surgical language it demands.
Okay, so let's start with the foundations, the building blocks. We have to begin with a modern definition of the mesentery itself.
Yeah.
Which is the collection of tissues that maintains abdominal digestive system organs in position and in continuity with other systems.
Okay, let's pause on that language. Collection of tissues, maintains position, continuity with other systems. You mentioned that in the past, centuries ago, it was defined differently by how it looked, a fold, membrane, sheet. But those words are now specifically left out. Why? For someone really trying to master this, why is deliberately excluding that classical terminology so important?
That omission is absolutely crucial because the old words, they sort of impose functional limits that just aren't real. Calling it a simple membrane or fold, well, it suggests it's thin, passive, and that's misleading for two big reasons. First, the mesentery actually loses that characteristic folded shape once you mobilize it, lift off of the back wall during surgery. It only looks like that when it's in place. Second, and this is really the main point, the mesentery has a substantial stroma.
Stroma.
Yeah, a robust, thick framework. It's connective tissue, fat cells, blood vessels, lymphatics. It's quite substantial. And this stroma, which often gets thicker and maybe more functional as we age, that's the actual powerhouse of the organ. Yeah. So if you only focus on the surface layer, the mesothelium, you completely miss its functional depth.
So it's the stroma doing the work, not just the thin surface.
Got it. And the description of its connectivity is different too. It's not just a tether to the back wall, it's more like a conduit.
Precisely. Its job is to maintain continuity not just between the gut and the body wall, but between the digestive organs and the major physiological systems. Think vascular, the complex nerve networks, and, critically, the entire lymphatic drainage system. Recognizing the mesentery as the main anatomical frame for all these systems. That's exactly why modern cancer surgery is so focused on keeping that mesenteric package intact.
Okay, next definition then. The peritoneum.
Right, the peritoneum. Yeah. It's this continuous, serous membrane supported by connective tissue lining the abdominal wall. The really key dynamic concept here is reflection.
Reflection, yeah. A reflection is that specific point where the parietal peritoneum, the part lining the abdominal wall, actually leaves the wall and merges onto the surface mesothelium of an organ. That could be the intestine itself, the mesentery, the liver, the spleen.
And why is that point of reflection so surgically important?
Because all these reflections, taken together, form a continuous mesothelial canopy. This canopy keeps the organs in place, which is good, but it also means this canopy often hides the deeper mesentery and the fascial layers surgeons need to get to. Which brings us to our next really critical term, peritonomy.
Peritonomy, the key to getting access.
Exactly. Since the peritoneum hides what's underneath, surgical access almost always demands a sharp cut, an incision, into this mesothelial canopy. That's peritonomy. It's basically the gateway to that crucial plane of dissection just beneath it. And, pathologically speaking, the peritoneum is also vital because it acts as a barrier, helping to limit the spread of disease within the abdomen, like malignant ascites.
Okay, final foundational piece, the fascia. Specifically Toldt's fascia. We hear this term a lot. Let's nail down exactly what it is and how it relates to the mesentery.
Right. Toldt's fascia is a distinct layer of connective tissue. It sits right between an organ like the mesentery or the duodenum and the retroperitoneum, which is basically the posterior abdominal wall itself. This fascia develops wherever a bit of mesentery or retroperitoneal organ becomes sort of flattened and stuck against that posterior wall during development. You'll find Toldt's fascia underneath, things like the bare area of the liver, the whole duodenum, the pancreas, and crucially, all those attached parts of the mesentery, like the right and left mesocolons. It's the tissue that provides that proper anchorage after gut rotation happens.
Okay, components defined. Mesentery, peritoneum, fascia. Now we shift to the action, right? The surgical lexicon. It seems centered on precise separation. And this starts with the idea of the plane.
Yes, the plane. It's such an essential concept for anyone doing this kind of surgery. We define it as a conceptual interface between two continuous and contiguous surfaces. It's not something you just see when you open the abdomen. It's a zone you have to surgically create. You have to develop it. And the most critical example, the one we keep coming back to, is the mesofascial plane.
The mesofascial plane, that conceptual zone right between the mesentery itself and that underlying Toldt's fascia we just defined. Okay, here's where the clinical relevance really hits. Why is operating within this specific plane considered, well, the safest and most oncologically sound approach for resections?
The gold standard. Because staying within that plane guarantees the complete integrity of the mesenteric package you're removing. Remember, we talked about the importance of the stroma and everything in it, lymph nodes, lymphatics, major vessels. Well, when you're doing a complete mesocolic excision, for example, staying in that mesofascial plane ensures you get every single lymph node draining that tumor out on block. It keeps it cleanly separated from the retroperitoneal structures like the ureter or the big vessels. This minimizes local recurrence, obviously, but also drastically reduces the risk of injuring something important. And because it's conceptual, developing, it needs really meticulous, gentle traction and countertraction right after you make that initial peritonitomy.
Okay, so the actual surgery then follows 3 steps based on this plane: separation, detachment, and disconnection. Let's walk through that progression.
Right. The first step is mesofascial separation. This is the physical act, the cornerstone of intestinal surgery. It's literally separating the mesentery from the underlying contiguous Tolchet's fascia using sharp dissection, sometimes a bit of blunt. Now, when you do this broadly over a large area, the result is mesenteric detachment. Detachment means the mesentery has been lifted completely away from the retroperitoneum. Its only remaining connections are to adjacent bits of mesentery or at specific, dense vascular points.
And the final step, the decisive one.
That would be mesenteric disconnection. This is the final division of all the remaining anatomical connections once you've achieved detachment. This means dividing the major vascular pedicles, any leftover mesenteric links between the part you're removing and the part staying, and finally the intestine itself. Once disconnection is done, the segment is totally free and ready for removal.
Now, to navigate this plane safely, avoid damage, surgeons need landmarks. That brings us to these adipovascular pedicles.
Yes, adipovascular pedicles. These are basically focal areas where fat and connective tissue naturally sort of pile up or heap around the major vessels. Think iliacolic, middle colic, inferior mesenteric arteries and veins. Their presence is a crucial navigation aid. They help the surgeon tell the difference between these dense vascular regions that need formal ligation and the less vascular, non-pedicular mesentery between them.
And we should probably stress these pedicles aren't always simple. They can contain more than just arteries and veins, right?
Absolutely. A classic example is the inferior margin of the ventral mesogastrium. Historically, people confusingly called it the hepatoduodenal ligament. This margin is thickened, and it forms the portal pedicle. This vital structure carries not just the portal vein and the hepatic artery, but also the common bile duct. So, yeah, surgeons absolutely must be aware that pedicles can house biliary structures alongside arteries and veins, all bundled together. Makes dissecting them highly technical.
Okay, so if the pedicles are the danger zones you handle carefully, where does the safe, controlled division usually happen?
That happens in the interpedicular regions. These are the areas between the major vascular pedicles. The mesentery here is typically much thinner. It's often quite translucent, actually, and contains minimal large vessels. Surgeons intentionally target these zones for controlled division because, well, the relative lack of blood vessels minimizes bleeding and allows for safer, quicker mobilization of those non-vascularized parts of the mesentery. Right, shifting gears slightly to embryology. Understanding the faults, the things that can go wrong congenitally, really requires understanding how it all develops in the first place. We tend to think about development in two main regions,
Mhm.
areas above and areas below the mesenteric root region.
Let's define that root region clearly. Where exactly is that?
The mesenteric root region, it's this narrow, absolutely crucial zone. It's where the mesoduodenum narrows down significantly just before it fans out into that huge, small intestinal mesentery. It's right there in the center of the abdomen,
Mhm.
very closely linked to where the superior mesenteric artery and vein originate,
Yep.
right around the level of the duodenojejunal flexure. It's basically the anatomical pivot point around which a lot of the rotational movement happens later.
Okay, so the two big developmental processes are rotation, then attachment. What's the main outcome of rotation of the midgut?
Rotation. It's this complex process where the whole midgut and its mesentery complex moves and shifts position inside the developing abdominal cavity. The functional result is that the small intestine and its mesentery get displaced centrally. They end up sort of wedged neatly between where the right colon and its mesentery will eventually be and where the left colon mesentery will be.
And attachment is the critical step after rotation that locks everything down.
Correct. Attachment is absolutely essential. It's the process where specific predetermined areas of mesentery, primarily the right mesocolon, the left mesocolon, the inner part of the mesosigmoid, and the mesorectum become flattened and anchored firmly to the posterior abdominal wall. And this anchoring happened physically because Toldt's fascia develops between the outer surface of the mesentery and the inner surface of the abdominal wall. This flattening and sticking down is what fixes the intestine in its predictable final spot.
And when these processes fail, that's when we get surgical crises. Let's start with non-rotation, sometimes called malrotation. This isn't just a twist. It's a fundamental failure of development.
Exactly. Non-rotation is basically an arrest, a halt in the embryological timeline. The right colon and its mesentery just don't make it fully over to the right flank where they belong. And crucially, because the mesocolon never gets into the right position, that necessary post-rotational attachment across a wide base, well, it just can't happen. This failure leaves the entire small intestinal mesentery attached only by that incredibly narrow, vulnerable root region we talked about. The consequence, the whole mesenteric complex can twist violently around this tiny attachment point. That leads to intestinal obstruction, what we call volvulus. And this often presents dramatically in abdominal crisis, usually in newborns or infants.
Then there's the subtler failure, non-attachment.
Non-attachment is different, yeah. In this situation, the actual positioning of the organs might look pretty much correct. However, that later step, the anchoring process via Toldt's fascia development, is inadequate. Maybe it's patchy, maybe it's completely absent. So the mesentery is in the right place, but it's just not secured properly. This also leaves the intestine prone to twisting in volvulus, but often it shows up later in life compared to malrotation, where symptoms are frequently right after birth.
What about things like structural gaps, like atresia or the mirrored anatomy in situs inversus?
Right. Atresia is a failure of formation. It's a localized gap in a region of the mesentery, and that leads to a corresponding failure of the connected intestine to develop properly. There's just a gap. Situs inversus is a complete reversal, mirror image. Left organs are on the right, organs on the left. The vital point for the surgeon here is that the actual conformation of the mesentery, its continuity, its attachment points stays anatomically normal. It's just flipped. So the surgical approach is consistent, just mirrored.
Okay, before we move to regional anatomy, one last point on these congenital adhesions.
Yes, congenital adhesions. These are adhesions that form naturally during development, not because of surgery or injury. They pop up between two peritoneal surfaces that have just been sitting in close, continuous contact for a long time while things are forming. Surgeons need to be able to tell these apart from the true peritoneal reflections we discussed. Classic examples. You often find them on the outer side of the mesosigmoid, where it presses against the peritoneum in the left iliac fossa. And also that natural sticking together that happens between the underside of the greater omentum and the top surface of the transverse mesocolon.
All right, now we're getting into the regional specifics, starting proximal, so above that mesenteric root region. This zone includes the mesogastrium, the mesoduodenum, structures really fundamental to complex upper GI surgery.
Let's start with the dorsal mesogastrium. This region is absolutely central to the anatomy of the lesser sac. It's located in the posterior wall of the lesser sac, lying just in front of the retroperitoneum. And critically for surgical strategy, Toldt's fascia is immediately behind it, which means you can actually lift the dorsal mesogastrium away from the retroperitoneum using those mesofascial separation techniques.
And tracing its continuity, where does it connect?
Inferiorly, the dorsal mesogastrium just seamlessly transitions into the mesoduodenum, Laterally, it extends out and becomes continuous with the splenic hilum, providing the framework for all the nerves and vessels going to the spleen. This continuity means the splenic vessels have to travel through the dorsal mesogastrium to get to the spleen, which makes mobilizing this region key in any pancreatic or splenic surgery.
Okay, next, the ventral mesogastrium. Part of this is commonly known as the lesser omentum, right?
That's right. The ventral mesogastrium basically acts like a bridge. It spans the gap between the liver and the lesser curve of the stomach, or the duodenum. Its structural continuity with the dorsal mesogastrium is what creates the pathway for branches of the coeliac trunk, the whole biliary tree, and the portal venous system to navigate this upper quadrant. It's essentially the highway for these critical structures.
And we need to stress the portal pedicle again. Its location within this mesogastrium.
Yes. The portal pedicle is simply the thickened, crucial inferior margin of this ventral mesogastrium. Its significance lies in the traffic jam of structures it carries. The hepatic artery, the common bile duct, and the portal vein all bundled together. Knowing this is just the bottom edge of the ventral mesogastrium really helps simplify its often confusing historical names and dictates how you approach surgery around the gallbladder or the liver hilum.
Moving slightly lower, we hit the mesoduodenum. What defines its relationship with the pancreas?
The mesoduodenum sits immediately behind the head and body of the pancreas, but in front of the posterior abdominal wall. It's firmly attached to the retroperitoneum by Toldt's fascia. As it goes distally, further down, it narrows considerably, forming that critical boundary near the mesenteric root region. Functionally, during development, this mesoduodenum acts almost like a cradle for the major vessels. It wraps intimately around the origin of the superior mesenteric artery, SMA, and the end point of the superior mesenteric vein, SMV, defining that vascular hub of the midgut. The head and the uncinate process of the pancreas end up nestled very close to, and often slightly below, the final position of this vascular root.
Okay, and finally in this upper region, the two big fibroadipose structures, the falciform ligament and the greater omentum.
Right. The falciform ligament, it's really just the most anterior leftover bit of the ventral mesogastrium. It's a midline structure connecting the liver to the front abdominal wall. Its bottom edge is marked by the ligamentum teres, the remnant of the umbilical vein. Important to remember, anatomically it is mesentery, not a ligament in the typical sense. Then there's the greater omentum, this huge fatty apron structure originating from the greater curve of the stomach, right where the gastroepiploic arcade runs.
How does the greater omentum interact with the transverse mesocolon? Why is that interaction important surgically?
It adheres extensively through those diffuse, often quite dense congenital adhesions we mentioned, to the upper surface of the transverse mesocolon. Dividing these adhesions, which is formally known as dividing the omenticolic reflection, we'll touch on that again, is a necessary first step for getting into the lesser sac and mobilizing the transverse colon during things like a colectomy or a gastrectomy. Also, the way the omentum attaches quite firmly to the splenic peritoneal reflection significantly complicates mobilizing the splenic flexure. It often requires a really difficult meticulous separation there.
Okay, continuing distally now, we're following the continuous mesentery through the entire lower digestive tract, so the unified path goes. Small intestinal mesentery transitioning into the right mesocolon, then the transverse mesocolon, left mesocolon, mesosigmoid, and finally the mesorectum.
Starting with the small intestinal mesentery. This really highlights the cleverness of its structure. Although its base, where it attaches near the right mesocolon, is relatively short, the edge of the mesentery that attaches along the small intestine itself is tremendously long, and it's highly flaplicated, folded back on itself many times. This plication is what allows for that massive internal surface area needed for absorbing nutrients, while still managing to keep the entire length of the small intestine packed neatly in the center of the abdomen.
And its connection with the appendix dictates where the appendix ends up, which is obviously critical in acute surgery.
Precisely. The mesoappendix, the mesentery for the appendix, originates specifically from the undersurface of the ileocecal region of the main mesentery. Now, if that particular part of the mesentery stays attached to the posterior abdominal wall via Toldt's fascia, the appendix gets directed backwards, resulting in that very common retrocecal position. And the clinical importance is heightened because that ileocecal mesenteric confluence, where the small bowel mesentery meets the colon mesentery, houses large amounts of highly organized lymphatic tissue, which explains why conditions involving lymphatic inflammation, like mesenteric adenitis or Crohn's disease, so often target this specific anatomical junction.
Okay, moving along the path. The right mesocolon is continuous with the small intestinal mesentery. And because of that post-rotational attachment process, it's fully secured to the posterior abdominal wall by Toldt's fascia. This brings us to the flexures, the corners, which can be complex.
Yes, the hepatic and splenic flexures. They're crucial turning points, and they share a common anatomical framework. We can understand them better by thinking about two perpendicular axes, one related to movement and attachment, the other related to sequence.
Right, the radial axis and the longitudinal axis. Let's define how they help surgeons.
Okay, the longitudinal axis is simple. It just describes the sequence, the transition from one region to the next. So from the right mesocolon to the transverse mesocolon, for instance. The radial axis runs from the central vascular pedicle, like the middle colic, outwards laterally towards the edge where the intestine is. This axis is critical because it marks a sharp transition. The part of the mesentery medial to this axis is often fixed or attached, while the part lateral to it is non-attached and mobile.
Okay, how do those axes apply specifically to the hepatic flexure, the right-sided one?
The hepatic flexure is basically the meeting point of the fully attached right mesocolon and the transverse mesocolon, which is attached centrally but pretty mobile out at its intestinal edge. So during mobilization, the surgeon is separating that fixed right mesocolon from the retroperitoneum while also respecting that transition point where the two mesocolons merge.
And the splenic flexure on the left. Usually much higher, tighter, notoriously tricky to mobilize.
It is. It presents the reverse setup, conformationally, and it involves a really dense, fixed attachment. It often shows extensive sticking adherence to the splenic peritoneal reflection and, as we mentioned, the greater omentum. This adherence requires really meticulous, sharp dissection to safely free up the colon without injuring the spleen itself, or the tail of the pancreas, which sits right behind the dissection plane.
Okay, the transverse mesocolon itself. It's defined by these two flexure components converging on the middle colic vascular pedicle. What's the key thing to remember about its attachment or lack thereof?
Yeah, this needs to be really clear. The transverse mesocolon does not have a formal, broad, linear attachment to the posterior wall like the right or left mesocolons do. While its vascular pedicle is fixed way back at the mesenteric root, the mesocolon itself is largely mobile. It's suspended by the dorsal mesogastroomentum complex above it and connected to the colons at the flexures laterally.
Got it. Finally, the left mesocolon and the pelvic regions.
The left mesocolon stretches from the splenic flexure down across the left flank. Just like the right side, it's fully attached to the retroperitoneum via Toldt's fascia. And it's continuous inferiorly with the medial fixed part of the mesosigmoid.
And the mesosigmoid anatomy brings back that risk of volvulus, the twisting.
It does. The mesosigmoid has a vertical axis that's the attached part running down from the left mesocolon towards the mesorectum. But its horizontal axis is where the variability and the trouble lies. You have attached, flattened regions near the transitions, but then this mobile, detached segment in between. The significant difference in length that can occur in this mobile part of the mesosigmoid is precisely why the sigmoid colon is so prone to twisting and developing volvulus, especially in adults. Then, distally, the mesorectum is just the continuation of that fixed mesosigmoid. It forms a predictable anatomical collar around the distal rectum, and it terminates exactly at the apex of the pelvic floor, just below the anterior peritoneal reflection. Okay, now we need to circle back a bit and give the peritoneum and Toldt fascia the detailed attention they really deserve, especially thinking about how surgeons use them as guides.
Right. Proximal to the root in that upper abdomen, what are the key peritoneal reflections surgeons rely on to orient themselves during complex surgeries?
Starting up high, you have the coronary and triangular reflections. These basically outline the edges of the liver's bare area, where it's directly touching the diaphragm. Medially, there are the lanorenal and lanophrenic reflections. These mark the lateral limits of the dorsal mesogastrium and the lesser sac, showing where the spleen is anchored. But probably the most significant reflection for mobilizing the lesser sac and the upper colon is the omentocolic reflection.
Okay, describe why dividing that omentocolic reflection is so important. What does it achieve?
This reflection connects the greater omentum to the transverse colon. Dividing this attachment is pretty much the required first step for most major upper abdominal procedures, because it allows the surgeon to lift the greater omentum upwards, exposing the whole expanse of the transverse mesocolon underneath, the pancreas behind that, and the structures within the dorsal mesogastrium. Without dividing this reflection, you just can't safely get into the lesser sac.
Okay, moving distally now. The peritoneal reflection of the small intestine continues down as the right peritoneal reflection, along that right pericolic gutter, the space beside the colon. This brings up that really crucial distinction you mentioned earlier between the reliable reflection and this historical marker surgeons are now warned not to rely on.
Yes, this is such a vital practical point. It's the contrast between the peritoneal reflection itself and the so-called white line of Toldt. Now, where the surface mesothelium of the attached mesentery meets the peritoneum lining the abdominal wall, sometimes you see this faint white trace. That's the white line of Toldt. Historically, some surgeons might have tried to start their dissection here, but the problem is this line is incredibly variable. Sometimes it's clear, sometimes faint, sometimes barely there, and its exact position can shift. It absolutely should not be relied upon to guide your dissection. The peritoneal reflection, on the other hand, is universally present. It's the geometrically predictable boundary between the attached mesentery and the abdominal wall. That is the only reliable starting point, the true surgical map for safe mesenteric mobilization.
Okay, clear distinction. And tracing that reliable reflection further down.
It continues as the left peritoneal reflection along the descending colon. Then it progresses down into the pelvis as the left and right perirectal reflections. These eventually merge, they coalesce, to form the absolute bottom endpoint of the peritoneal cavity.
And where exactly is that anatomical endpoint located?
That's the anterior reflection. This marks the furthest point the peritoneal cavity reaches inferiorly. It's formed by the union of those left and right perirectal reflections. In males, this reflection drapes over the back surface of the bladder, forming the rectovesical pouch. In females, it drapes over the posterior surface of the cervix and the uterus, forming the rectuterine pouch, which you might know as the pouch of Douglas. This landmark is absolutely paramount for defining the upper surgical boundary in pelvic floor surgery and rectal cancer surgery.
Now, back quickly to Toldt fascia. We established its continuity, but it gets confusing regional names. Let's clarify those pelvic condensations again.
Right. Toldt's fascia is fundamentally one continuous layer, anchoring viscera to the back wall. On the right side, it's often continuous with the capsule around the kidney. On the left, it's frequently referred to interchangeably with de Roda's fascia, which is the fascia encapsulating the left kidney and its surrounding fat. The critical concept, though, is that these are just regional descriptions. The connective tissue sheet is continuous.
And in the pelvis specifically, we hear about Denonvillier's and Waldeyer's fascia.
Exactly. These are specific dense condensations or thickenings within that continuous Toldt's fascia. They aren't separate anatomical things, but thickened areas serving distinct anchoring jobs. Denonvillier's fascia is that dense condensation found anteriorly in the pelvis. It separates the mesorectum and rectum behind from the prostate and seminal vesicles in males, or the vagina in females in front. Waldeyer's fascia is the condensation found right at the apex, the bottom tip, of the mesorectum. It attaches the mesorectum to the sacrum and coccyx and really defines the distal boundary for a total mesorectal excision dissection. Recognizing them just as regional names for parts of the continuous Toldt's fascia really unifies the surgical concept. Okay, now we come back to that fundamental principle, the mesenteric frame concept. The idea that all the major arteries, veins, lymphatics, and nerves use the mesentery as their anatomical framework, their highway, to reach or drain the digestive organs. This is precisely why mobilizing the mesentery first is the prerequisite for safely controlling these vascular structures.
Right. Let's trace the arterial supply then, starting up top with the coeliac trunk and how it navigates through the mesogastria.
Okay, the coeliac trunk. It comes off the aorta and immediately dives into the dorsal mesogastrium. It usually trifurcates, splits into three: the left gastric, the splenic, and the common hepatic arteries. The left gastric artery uses that continuity between the dorsal and ventral mesogastria to get up to the lesser curvature of the stomach. The splenic artery runs posteriorly within the dorsal mesogastrium out to the splenic hilum. And crucially, the common hepatic artery first travels within the dorsal mesogastrium, then makes a sharp turn to enter the portal pedicle, remember, that thickened bottom edge of the ventral mesogastrium on its way to the liver.
And the arteries distal to the root, governed by the superior and inferior mesenteric arteries, the SMA and IMA.
Exactly. The superior mesenteric artery, or SMA, originates right at that root region and immediately plunges into the mesentery proper. It gives off the middle colic artery, which travels within the transverse mesocolon, and often the right colic artery, which uses the continuity between mesenteries to enter the right mesocolon. The inferior mesenteric artery, or IMA, enters the left mesocolon. It gives off the left colic artery and then continues downwards as the superior rectal artery, running centrally within the mesosigmoid and then the mesorectum. And it's vital to remember that all these major arteries feed into a continuous arterial arcade, like a loop, located right where the mesentery meets the intestinal wall.
Okay, venous drainage. It follows a predictable path generally, but with some important variations surgeons need to know. Let's start with the inferior mesenteric vein, the IMV.
Right, the inferior mesenteric vein, IMV. It runs upwards within the left mesocolon, heading proximally back towards the mesenteric root region. However, where it ends, where it drains into, is quite variable. Most commonly, it joins the splenic vein, usually behind the pancreas. But surgeons absolutely must be ready for common variations where the IMV might join the superior mesenteric vein, SMV, directly, or even join right at the point where the SMV and splenic vein meet to form the portal vein, the portal confluence. This variability really impacts the technical difficulty of doing a high ligation of the IMV during left-sided colon cancer surgery.
And tracing the SMV path back towards the liver.
The superior mesenteric vein, SMV, runs up through the small intestinal mesentery, passes through that crucial root region, and continues traveling through the mesoduodenum. It then joins the splenic vein, typically behind the head of the pancreas, and together they form the portal vein. The portal vein then leaves the mesoduodenal mesentery behind and enters that critical anatomical bottleneck, the portal pedicle, within the ventral mesogastrium, on its final journey into the liver hilum.
So this mesenteric frame organizes everything then, not just arteries and veins, but the less obvious systems too, like nerves and lymphatics.
Absolutely. The organization is comprehensive. The lymphatic drainage follows the arterial supply precisely, which is what makes lymphatic mapping and clearance predictable in cancer surgery. Innervation follows this frame too. You have preganglionic sympathetic nerves traveling via the splanchnic nerve and parasympathetic input via the vagus nerve. Both systems distribute their fibers through complex nerve plexuses housed within the connective tissue and stroma of the mesentery itself.
Okay, we've built the anatomical foundation. Now let's really cement the application. The consensus seems crystal clear. For cancer operations, mesenteric-based surgery procedures like complete mesocolic excision, or TME, is the gold standard. It's associated with the best outcomes. Why is sticking so rigidly to this anatomical frame absolutely critical in oncology?
It's critical because the mesentery as this functional organ acts like a self-contained envelope. It holds the tumor's entire primary lymphatic drainage field within it. So by performing that meticulous mesofascial separation and removing the entire mesenteric package en bloc intact, the surgeon achieves the highest quality resection. You minimize the risk of leaving behind any involved lymph nodes, and you ensure clean margins relative to those critical retroperitoneal structures lying just behind the fascia.
And the danger of straying, of going outside that established mesofascial plane during dissection?
Oh, digressing from the plane is highly hazardous. The moment a surgeon breaches that Toldt's fascia boundary, they're entering the retroperitoneum. This significantly increases the risk of iatrogenic injury accidentally damaging things. The ureters, the duodenum, the common bile duct, the pancreas, the great vessels like the aorta and vena cava, they all lie immediately posterior to this plane. Any break in following the mesenteric roadmap increases complication rates, bleeding risk, and critically, it compromises the oncologic quality of the specimen you remove.
We touched on this earlier. The approach seems to differ slightly proximal to the root. While distal surgery is strictly mesenteric-based, what does that hybrid approach proximal to the root actually involve?
Right. Distal to the root, for the colon and rectum, we rely entirely on mesofascial separation first. Proximal to the root dealing with the stomach, duodenum, pancreas surgeons often use more of a hybrid method. Because the major vessels like the celiac trunk and the SMA originate so centrally and are deeply embedded, the traditional approach often involves dissecting directly through the dense tissues of the dorsal and ventral mesogastria and the splenic hilum to find and ligate these major vessels right near their origins. It's less about mobilizing the entire mesogastrium off the retroperitoneum first and more about direct vascular control in that complex area.
Okay, let's cover a few quick technical tips or anatomical angles to keep in mind. What about the general orientation of the upper abdominal organs?
A key visual to hold on to is the oblique orientation. The pancreas doesn't lie flat horizontally. It runs obliquely upwards and to the left across the retroperitoneum. The transverse colon is also highly oblique. Why? Because the splenic flexure is typically positioned much higher up in the left upper quadrant, while the hepatic flexure tends to sit lower down, tucked under the liver. Recognizing this spatial geometry, this slant, is essential for mobilizing the colon evenly and safely. And further down, recognizing the proximal and distal mesosigmoidal angles, those points where the mesentery transitions from fixed to mobile, is really key for both surgical planning and also for navigating safely during colonoscopy.
Perfect. Now let's synthesize all this knowledge using those clinical cases mentioned in the source material. Let's use our new precise lexicon. Case 1. A patient presents with a perforated retrocecal appendix.
Right. This case directly tests your understanding of mesenteric origin and attachment. Because the mesoappendix originates from the undersurface of the ileocecal mesentery, and that part of the mesentery is attached to the posterior wall. Well, the appendix itself ends up hidden behind the mesentery in the retrocecal space. So to safely see and manage that perforation, the surgeon can't just lift the colon out of the way. They must perform a peritonomy along the line of the peritoneal reflection. Then they need to execute mesofascial separation, detaching that ileocecal mesentery from the posterior wall. Only then can they expose the infected retroperitoneal space where the appendix is actually lying.
Okay. Case 2. A patient with recurrent abdominal pain, found to have volvulus due to non-rotation. A failure of attachment.
This is a classic illustration of what happens when that mesenteric base stays too narrow because development didn't complete properly. The small intestine is just inherently prone to twisting. The surgical fix involves 2 key steps. First, you have to perform extensive adhesiolysis, cutting any abnormal bands to restore the correct anatomical conformation, untwisting everything. Second, and this is crucial, the surgeon must actively recreate the peritoneal reflection. This is often called a pexy. You actually suture the mesentery to the posterior abdominal wall over a broad area. This enforces proper attachment, prevents it from rotating again, and fixes the underlying mechanical issue.
Finally, case 3. The really interesting implications of the mesentery's role in Crohn's disease. This challenges that old view of inflammatory bowel disease as just being about the gut lining, the mucosa.
Yes, this is perhaps one of the most exciting clinical shifts being driven by this better anatomical understanding. Traditionally, Crohn's was seen mainly as an intestinal problem. When surgeons resected diseased bowel, they often left the adjacent, thickened, fatty mesentery behind. But now, there's compelling evidence emerging that suggests the mesentery isn't just passively involved, it's pathologically active. It's full of inflammatory cells, and it seems to be driving disease recurrence. Studies are showing that including that abnormal diseased mesentery in the resection specimen actually leads to better long-term symptom-free outcomes compared to the old approach. This provides pretty direct proof that events happening within the mesentery are crucial drivers of the disease's pathobiology. #outro.
Wow, that was certainly a deep dive into surgical architecture. I think we successfully navigated that transition from the outdated idea of multiple passive folds to the modern reality of the mesentery as the single continuous functional organ. We defined the key components, the continuous peritoneum, the anchoring Toldt's fascia, and hopefully helped master the specific surgical language needed for elite practice. That mesofascial plane, separation, detachment, disconnection. We now really understand how that anatomical continuity dictates the safe, predictable pathways for all the major vascular, lymphatic, and nervous systems.
Absolutely. The required shift in perspective, I think, is complete. Achieving mastery here means moving beyond just naming parts. It means internalizing the mesentery, the peritoneum, and the fascia as one single interconnected functional system. By operating meticulously within that conceptual mesofascial plane, guided always by the reliable peritoneal reflection, we ensure safe, predictable, and oncologically sound resections throughout the entire length of the digestive tract.
Which brings us neatly to our final thought for you, the listener, to mull over, building on those profound implications for inflammatory disease like Crohn's. Given this compelling new evidence that the mesentery is actively pathologically involved, acting as an inflammatory driver, not just passive support, what future advances might we potentially see in non-surgical gastroenterology therapies? Therapies that specifically target the cellular and connective tissues within the mesentery itself, rather than limiting treatment primarily, as we do now, to the intestinal lining.
It's a fascinating question. The research implications of this anatomical reclassification are really still unfolding, and they promise potentially entirely new therapeutic pathways down the line. Thank you for joining us for this deep dive.
We'll catch you next time.